So for those of you who don't know what the Sanford Guide is, here's an actual book. A long time ago, it's an old version. You guys want to flip through it to see what's actually in it. I'll leave it right here. You guys can flip through it whenever you want. That is one of the best books that we have for ID. Okay. All right. So yesterday we left off with vaccines for influenza. This is basically indication for vaccination. Obviously, filter folks. Anywhere where we really congregate groups of people, especially groups of people that have low immune system issues, really should get influenza areas, places that can have possible outbreaks. AIT, for example, is training, for example, really should get it right because they can pass it on to each other because they're in such close quarters. Okay. We also have some contraindications of vaccine. This used to be an old school issue, right? Cell-based rather than egg-derived. Read your package insert for your vaccination, and that'll tell you whether it is or it is not egg-derived, and it'll tell you if egg allergy is a contraindication or not. Some of the newer ones are no longer contraindications, even if they use egg protein to develop some of the vaccinations, because the filtration system has been improved so much. You have minimal protein in there that causes those people the allergy or the allergic reaction. But again, read the manufacturer's package insert if that is of concern, because we have so many different manufacturer type of immunization for influenza. It's really based on the manufacturer and how they make it. Reactions to thimerosal. I mentioned a little bit about it yesterday. Thimerosal is a preservative that they used to use in vaccinations. The uproar was so huge. Most of the vaccines no longer have thimerosal in it, but there are very few that do. I'm sure you read your package insert to see if they do. They used to have them in contact lenses solution. It used to irritate the eyes a little bit. If you go to underdeveloped countries, some of those contact lens and eye drops still have some thimerosal in it. Most of the ones in developed countries no longer have thimerosal in it. If you read the package label, it'll say preservative free. Preservative free is really what you want. Because thimerosal was the preservative that they used to use. If an individual is actually febrile, do not give them the medication, or do not give them the influenza vaccine. Okay? Do not give them the influenza vaccine, just let them come back. And then if they have history of Guillain-Barré syndrome, which is a possible side effect of the vaccine, do not give it to them either. Guillain-Barré is a neurologic issue, starts to work its way up, and you eventually stop breathing. So if you ask them, hey, have you ever had Guillain-Barré syndrome? And they go, what's that? They probably have never had. So it's something that you will probably remember for the rest of your life because you end up in a hospital for that. Okay, here's some misconceptions. It's just a nuisance, not a lethal disease. Not a lethal disease for you if you're healthy, but it can be a lethal disease for older folks or immunocompetent folks. Okay, neutropenic folks. Right? Folks that are on chemotherapy, it is lethal for those folks. Okay? Vaccine causes the flu. We use an inactivated vaccine, so it does not cause the flu. It stimulates your body to react as if you have the flu so that you can develop those antibodies against it. As you said, vaccine doesn't work. Remember, antigenic shift and antigenic drift, right? Drift is the one that changes those proteins every year, which is why we need to get a new influenza vaccine every year. Okay? So sometimes we get it right, sometimes we don't. Okay. There's some bigger numbers there, 79% effective in preventing influenza, not 100%. Okay, not 100%. We do need to be honest with the patients that we're taking care of, so we can let them know there's nothing that we have that's really 100%. Okay. And it definitely does reduce hospitalizations in the elderly and increases death in the elderly as well. Okay. Viral pneumonia, non-productive cough, gradual onset. Keyword there, gradual onset, malaise, mild constitutional symptoms, cough, wheezing. You may want to highlight that, but there's several different things that can cause that. The deal with viral pneumonia is there's a whole bunch of different things that can cause viral pneumonia. It's very hard to pinpoint. Okay. Here it tells you you got some low-grade fever, but here, a whole bunch of stuff that can cause you viral pneumonia. Okay, so it's very hard to say this is what causes it, this is how we treat it. It's viral, so They don't do tons of stuff. Now, with all that being said, the way the CDC is and the way the political stuff is up at the top, it's beyond us, but it is affecting us as providers. Okay? Here it says measles. Right? In my lifetime, I've never had to take care of a measles case because we have measles vaccine. Right? As you guys start coming up, if we continue to go down the road we are, or we stop doing vaccinations, you may start seeing some of these old world disease processes that we haven't had in the past, or at least we haven't had for a long, long time. So some of these things you may actually start seeing once, as I am practicing currently, we're really not seeing much, but we're starting to see the emergence of measles throughout a whole bunch of different states. And if we continue without vaccines, this may become an endemic thing again, as we used to have it back before we had those vaccinations. So some of these diseases we generally do not see nowadays, you guys may see. Right, so keep that in mind as well as we go through some of this stuff with diabetes. Here, measles pneumonia used to be number one, right? Why do we put that on there? Because if measles continues to go the way it's going, it may end up coming back and it may end up becoming number one. And right now it's rare. We still have it somewhat of an outbreak in certain states. It continues to grow. But things to keep in mind. Varicella pneumonia, rarely seen in children with varicella, but adults are immunocompromised. If you do get it, it's a lot worse for us, right? If you get chickenpox, it's a lot worse for us. Yes, ma'am.
Question. So, the measles vaccine, is it required for children?
Right now it is. There are some states right now that are thinking of getting rid of the requirement. Florida being one of them. Okay. So, okay, I'm not here to bring up the political things, but I do need to bring that stuff to your attention because you guys are going to be practicing in that environment. So these are going to be some of the things that you guys may see. Okay, as we continue on with medicine the way it is. Okay, you do know chickenpox is worse for adults. This is why that's more severe for us, especially in immunocompromised. Okay. Cytomegalovirus doesn't usually affect healthy folks, right? We do know cytomegalovirus is more of an opportunistic infection and usually attacks the immunocompromised or the neutropenic. Right? So that's where the cytomegalovirus usually attacks or effects. And there it says most common are the post-transplant pneumonias. Usually you'll end up with some interstitial pulmonary infiltrates. If you do isolates from the bronchus, you may find more than just one issue. All right? It may actually not just include viral issues, but it may also include bacterial issues. So you may find more than one pathogen if you do bronchi isolates from the patients. HSV pneumonia, pretty exclusive. It's immunocompromised folks. Generally, the healthy folks don't get it. So there's your pool. Transplant patients, HIV/4/7-mediated neonates. Neutropenic patients can also be on there. What are we going to do to treat or prevent high-dose acyclovir? IV, keyword is IV acyclovir. Okay. In this case, we do not have IV valcyclovir, so the only option that we have is IV acyclovir. Okay. So this one's pretty specific. Okay, what are we going to do for some of these things, lab test-wise? Okay, try to do some viral detection. So HSV will do an antigen detection, whether it be immunofluorescence or PCR, whichever is available. PCR obviously is probably the best. If it's available, go with PCR. CMV antigen detection. Measles uses a hemagglutination test. It glutenates the proteins on blood, and then that usually tells you whether it is or it is not measles. Or you can do a viral culture. Remember, that takes a little while to grow out. And then varicella antigen detection. Okay, I wouldn't do too much on this slide. don't concern yourself too much with this slide. All right, and the reason why I say that is some of these viral pneumonias, when you do a chest x-ray, are really non-specific. We're trying to put some specific pieces on here. For example, with CMV, you can get diffuse interstitial involvement, but the problem is you can get diffuse interstitial involvement with HSV too. So don't worry too much about this slide, because some of the findings of some of these chest x-rays and some of these viral pneumonias really overlap themselves, and depending upon when in the point of the illness you capture, they may kind of sort of look alike. All right, so I'm not going to stress too much on this slide. As we move forward, some of the other respiratory stuff, I will tell you, hey, keep an eye on this chest x-ray result, but these, don't concern yourself too much with this one, okay? Oops, flesh. Okay, hantavirus. All right, two hantavirus cardiopulmonary and hantavirus pulmonary. Excuse me. Really, we're going to talk about hantavirus pulmonary. Okay, it enters the respiratory tract. It infects your endothelial cells. The endothelial cells are the lining of your capillaries. Okay, you guys remember that from anatomy. And it can spread systemically once it passes the lungs. But its main target is your pulmonary capillaries. All right, hence hantavirus pulmonary syndrome. Right. So these things target those capillaries. Now, what it does is it loosens the junction between the pulmonary capillaries. It loosens the junction between your endothelial cells inside your capillaries. Okay? So in turn, what that does is it causes leakage out of your vessels, particularly your pulmonary capillaries. What happens after your pulmonary capillaries start leaking? Right? After your pulmonary capillaries start leaking, you start getting fluid inside your lungs, right? And that's not good. You start having breathing difficulties, leading to hypoxia, you can't breathe. As it continues on, it ends up becoming systemic. Now you may start having some leakage in other capillaries around your body. All right? So if that happens, you may end up having hypotension and shock because you're losing so much fluid out into the body. Okay? So that's usually the way hantavirus works. Okay, how do you get it? Usually you get it from urine, droppings, and saliva from rats or rodents. Okay. What's the most common that usually you see from this? Say, for example, one of you is going to go to a cabin someplace that you got online for vacation, right? You go in and you see stuff is like dusty and dirty, and you grab a broom and you start sweeping it. You're aerosolizing all those rat droppings. You're aerosolizing the rat urine. Okay, where the saliva spit all over the floor, and as you aerosolize it, you inhale it. That's usually the most common way that you end up getting hantavirus. There are specific parts within the United States that you get hantavirus. Here it tells you four corners. All right, four corners would be in Arizona, Colorado, New Mexico, and Utah. All right, so if I'm going to put you in a scenario, or Chance is going to put you in a scenario, when we talk about hanta, it's going to involve one of these four places, because if it's within the United States, those are the highest level of cases that usually you find within the U.S. Right? Usually it happens sporadically, more common in the rural areas, okay, where forest, fields, and farms, where it's suitable for those little rodents to live. So remember location, remember places. Okay. And this one, even though it's respiratory, you can't spread it from person to person. Okay. Mortality rate, no treatment, usually 30 to 40%. Okay, so here's your little map. Okay, there's your four corners: Utah, Colorado, Arizona, and New Mexico. Okay, so here's signs and symptoms: fever, chills, myalgias. There's not really tons of stuff here. You can highlight myalgias often in back and legs. Right? So when we talk about flu, usually flu is your entire body, not more common in the back than your legs. Some larger muscles there. So that's a good one to highlight. looking at the signs and symptoms, there's really not much to go off of there. These things usually develop between 1 to 8 weeks after inhalation. Okay. There's some more findings. You get tachypnea, fever, and tachycardia. Right? You can highlight crackles because you're probably not going to see crackles in too many of these things. Right? You get that tachypnea because you're having difficulties breathing, right? Because you got fluid in your lungs, because your capillaries are leaking. You end up with tachycardia because your heart's starting to pump harder, trying to get that oxygen and carbon dioxide exchange. It's not working very well because you got much fluid. So you end up with a whole bunch of other issues. Now it's pretty specific here. It says no petechiae, okay? Which is important because when we say what's going on, it's capillary leakage. Right? Capillary leakage usually means it's just fluid leaking out of your vessels all over, which eventually you'll get petechiae all over your skin when it becomes systemic. But generally that doesn't happen because it's much smaller bits until it continuously develops later on. For the most part, usually you don't get to that point. And then hypotension, why? Because you're losing all your fluid. And then respiratory distress because your lungs are filled with fluid. So hemoconcentration. Why do you have hemoconcentration? Well, you have increased hematocrit because you're losing all the other stuff in your blood. Right? You're losing all the other stuff in your blood, so you're going to have a hemoconcentration in your system. You're going to end up with thrombocytopenia because all your platelets are going to try to plug up all the holes in all your vessels. There's just not enough. Right? There's not enough. So you're going to end up with thrombocytopenia. You'll have PTT, right? Those are all blood clotting issues. Due to the leakage, okay, you have CPK, which will be popped up because of the muscle damage. You'll have AST, which will be liver and other organs within your body getting damaged. So that's going to end up being elevated from ALT. And then, what else we got? LDH. Okay, that's more cellular damage. Definitive diagnosis, serology, PCR, ELISA, IgG or IgM. IHC is immunohistochemistry. It's a lab technique pathologists use to look for signs of disease in tissue. So if you're not taking a tissue sample, if you're not a specialist, usually you won't do for this. So immunohistochemistry is kind of way down the bottom of the list if you're doing kind of that stuff. So I remember this X-ray result. All right, mild interstitial pulmonary edema, right, because of the leakage, but then rapidly progresses basilar or perihilar pattern pleural effusion with disease, right? So it's going to end up starting down here. Okay, basilar, bottom, right? Perihilar, it can progress up here. And generally, because of gravity, you're standing up, and all of it is going to affect your sulci. Okay, so rapid progression. So you talked, this guy showed up the 27th, okay, you can see a little bit, right? His sulcus is completely down on both levels, right? On the 30th, 3 days later, it's all the way up perihilar, halfway up his lungs already. Okay, that's your rapid progression. And these folks usually end up in the hospital. All right, so this rapid progression was within 3 days. Okay, so here are some complications of what can occur. You can end up with DARS, cardiovascular collapse, respiratory collapse, anoxic brain injury. You're not getting any carbon dioxide oxygen exchange, so your brain's going to start to suffer. Right there, so a bunch of different things there for complications. Okay, so there is no specific treatment, cure, or vaccine for Hunter infection. We don't have anything. Okay. However, if you do recognize it early, and we do give ribavirin, we have much better outcomes with patients who have had hantavirus. earlier you can diagnose and the earlier you start them on ribavirin, the better off they're gonna be. Okay? Because otherwise we don't have anything else. And the rest of it's gonna be mostly supportive. May end up in the ICU intubated on a machine. Alright? Until the thing kind of sort of passes. Okay, bacterial pneumonias. Okay, there's a whole bunch of them. These are all community acquired pneumonias. Just keep an eye on the Legionella, Mycoplasma, and Chlamydia. They are atypical organisms. What that really means is that they're going to present in a slightly atypical way. They're going to present in a little bit different than the standard Streptococcus pneumoniae. Okay. Okay. Chlamydia. Talk about that in a minute. All right. Patients with immune host deficiencies are usually the folks that have most issues. Okay. So weakened immune systems, various conditions or procedures such as bowel resections put these people at risk. Okay. They're at higher risk for infection involving both aerobic and anaerobic bacteria. And they can also have issues related to upper respiratory tract disorders. At the bottom there it says consider multiple bacteria during one illness. So if you have any of those, bronchopneumonia, aspiration pneumonia, right? If you have either of those three, to include lung abscesses, you may want to go ahead and take a biopsy and send off to the lab, because with those three, you're thinking of possible multiple pathogens causing those problems. And then you should really do a culture sensitivity for those three, because then they can kind of tell you what specific medications you really need to treat those. So Streptococcus, or aka pneumococcal pneumonia, most common community-acquired pneumonia, period. You want to highlight something, highlight it is the most common community-acquired pneumonia. Okay. This is your patients that are at risk for this, or mostly at risk for this. And it's nothing really different than we really haven't seen. These are all patients that have some sort of immune issue. Right? You have ischemic patients, those are patients with no spleen. Okay? Your spleen helps your immune system. Right? Develop, that's like the center hub for all of your IG, IgG, and all that other good stuff for your immunity. We have patients with an altered immune function. So here, you're not seeing anything different for the populations that's really most at risk. The things to remember on here, elderly. Okay. Elderly is a good thing to remember on here. Alright. Now remember, the pneumococcal infections, the streptococcus infections, can affect a lot of other things too, not just the lungs. This can cause ear infections, it can cause sinus infections, so there's other possible things that can also be caused by streptococcus. Okay, here we're really focusing on the pneumonia aspect of streptococcus. So another thing to highlight, there's only two that we're really going to mention that say may follow viral upper respiratory infection. So this guy right here may show up in your office, you're going to be like, oh, okay, it looks like you have the flu. All right, go home, get some rest, drink some water, and plenty of fluids, you know, here's some Tylenol. 2 to 3 days later, they're going to come back to you. They're going to tell you, hey, I'm having problems breathing. I'm tired. It's getting worse. Okay? That's the presentation that this guy's going to do. Right? When he comes back, he's going to probably have some systemic symptoms, which will be the high fever, the rigors of prostration. Prostration being extremely exhausted or lack of power or energy, okay? Which is something a little bit different that we're not seeing in any of the other ones. Rigor is another one that we're not seeing in some of the other ones either. All right. The key is that this guy's following the viral upper respiratory infection, he's following back up, because he's getting worse. Okay. The weird chest pain, I would probably highlight bloody resting sputum, not something that we haven't seen, right? This block, we are not talking about tuberculosis, so likelihood of being tuberculosis is very, very minimal. Okay. Dyspnea, hypoxia, hypoxemia, tachypnea, it's affecting his lungs, so he's having difficulty breathing. 30% of them are usually associated with bacteremia. Okay. Very, very small percentage with meningitis. Very, very small percentage with meningitis. But if you do see some meningitis symptoms, go ahead and do a lumbar puncture and send that off. Okay, so here's your chest x-ray. I would probably remember that alveolar pattern. Okay. That'll be one of the ways that you can denote the difference with this. Do that alveolar pattern that you'll notice on chest x-ray. That really tells you that there's presence of fluid or inflammation in the small air sacs of the alveoli. You have to remember that from radiology. Okay. Air tells you it can be multi-lobe or a single segment. Again, the problem with some of these when we give you chest x-ray results is it really depends on when we capture it, right? If we capture it right away, if it's really early and they still don't have any respiratory type symptoms, you may not see anything in chest x-ray. But if they're coming back, and this guy is like, hey, he's back in the office 2 days later after you told him he had influenza, you may capture something, right? It may be the first load that may be infected. So it's really dependent on when you catch the disease process. All right. Another big thing is that radiologic resolutions lag in clinical recovery. So after you've treated the patient may actually feel better, but when you do another chest x-ray to compare, hey, do you look better? Because we'll take the old one and we'll put it next to the new one. It may look a little better, but it still may look like it's still infected. So the resolution for inside the lung may take a little bit longer. Yes, ma'am.
I'm good, sir. I was just screen looked like it was moving. So I just wanted to, I was trying to make sure I wasn't seeing stuff.
Freaking out?
Yeah. It's not that bad.
Wait for a minute. All right. What else we got? You do blood culture, you can grab standard. Sputum culture is probably the best one. Right? Sputum culture is probably the best thing to do if you're really trying to find something. Okay? You can do pneumococcal antigen, sputum, blood, CSF, urine. CSF only if you're actually thinking meningitis. Right? So here's some tests. You can do CBC to show you your leukocytes. I think those are going to be up. Probably, right, because it's got some further infection. Okay. PSR and CRP are going to be up. There is some inflammation going on. Right? And CRP will be up because of the inflammation and the infection. Okay. So both of those will be up. So here's where it gets a little dicey down at the bottom for treatment. Drug of choice for people with comorbid conditions. Augment. Key point. People with comorbid conditions. Now remember, did you remember that list that we had at the very beginning? There's a whole bunch of people that were sick. So they've already got some sort of condition. So most of the folks that are usually going to be susceptible to this are probably going to get augment. Okay? Now, if you show up and it is a penicillin susceptible area, I will probably give you azithromycin, clarithromycin, or doxy, one of them. Pick one. Okay. The big problem with this streptococcus or pneumococcal pneumonia is that there are a lot of pockets within the United States that are resistant to meds. Now, the nice thing about augmentin is that it's got the clavulanic acid at the very end there that'll break the outer shell of that bacteria so that your amoxicillin can actually get in and kill it. So that's nice, but the other ones don't have that. So be careful. If depending upon where you work, okay, what state you're in, is whether or not there is or is not resistance. Okay. Now, if there is some penicillin resistance, then you can use some levofloxacin or moxifloxacin. Okay. I'd like to give you some choices, especially if you talk about something that actually has had a lot of resistance within the U.S. Prevention pneumococcal vaccine, specifically for folks greater than 65 years of age. I see commercials all over TV for this stuff. Okay, there's plenty of vaccine choices that you can get. Okay. If you have high-risk medical conditions, right? Everybody on that front list, they all have medical condition of some sort, should get vaccinated. Here it shows splenectomy. Why? Because that filters your blood, it removes old damage your blood cells, helps fight infection, it produces antibodies and stores immune cells. So if you are going to get a splenectomy, please have them updated on their vaccines, particularly pneumococcal, especially if they're older than 65, so that they can develop that protection before you remove that nice hub for storing other immune cells. These are atypical pneumonias, right? These are a little bit different. Okay, they have a different pattern. Okay. They have mild to moderate symptoms. Okay. Researchers finally noticed that some of these are presenting a little bit different than some of the other pneumonias. So they ended up coming up with atypical. So these ones are atypical pneumonias. They may have a slightly different chest X-ray. They may have slightly different symptoms. They may respond a little bit differently to certain antibiotics. Right? So this is one of the reasons why they are considered atypical. Okay. 3 points on the bottom: your mycoplasma, your Legionella, and your chlamydia. Will be the 3 that we kind of sort of talk about. Okay. Most common cause of community-acquired pneumonia in young individuals, mycoplasma pneumonia. So I'll probably highlight that, right? It is the most common. Right. Since it is the most common, we're talking healthy people, 5 to 35. Okay, so now we're talking people like us, healthy folks. This one has sporadic outbreaks, affects young children and adults. I would highlight associated with acute media, sinusitis and bronchitis. Because this thing can also cause some other things, just like other pneumonia. Okay? Except for this one is pretty clear on here that it's associated with acute myocarditis. And that usually happens in small kids. And here, your range starts at 5 years of age. This is what bullous laryngitis looks like. Okay, this is your eardrum, but this is the bullous part that we're talking about. Okay, pop it out. That's on your eardrum. This is less abrupt. Okay, usually less severe, but you still have the same type of symptoms: fever, malaise, headache, cough. Right. You may have local crepitus virilis, without consolidation, so you may want to highlight that little section there. Because aureus, 7th aureus carriage in 30% of the population. What does that mean? So there's 30% of people carry Staph aureus on their body or in their nose, and they are asymptomatic. Some of those folks can spread it to other folks, and that's how we spread some of this stuff. All right, that's really what that means. High-risk folks are young and the elderly. Okay, so this is the one that's actually kind of attributed to the normal pattern, which is usually young and elderly. Okay. If you do have pre-existing lung damage, this may get you a little bit easier. Okay. Staph aureus pneumonia in children first 8 weeks of life. Okay, they are very susceptible in that time period. Here for other kids, it may precede another type of viral infection, and this is pretty rapid clinical deterioration, right? Because we're talking to kids. Kids do not have the compensatory measure of immune system to work that help them, which means when they get sick, they're okay, and then as soon as they get really bad and they can't compensate, they just go off the cliff. Boop. Okay. For adults, we're good, we're sick, but then we steadily decline because we have a decent immune system to fight them. Okay. Kids do not, so they have a rapid clinical deterioration as soon as they can't handle it anymore. Okay. So again, if this person comes to your clinic, right, they're going to show up with some of these symptoms. Some of these symptoms are going to look like the flu. You may tell them, hey, go home, get some rest, drink some fluids, take some Tylenol. You may get better. This guy will come back to your office in a couple of days and tell you that he's feeling worse. All right? So this is two that you may think it's the flu, send them home, and then come back later because they're getting worse. All right? Rigors, sputum may be bloody. So this is number 2 with bloody sputum. Okay? Here's a chest x-ray, patchy consolidations, rapid progress. And just like the other one, usually within 2 to 3 days, it could be both lungs or it could be one single lung for infection. That pneumocystocele, all that really means is there are air fluid cysts or cavities inside the lung tissue. Usually doesn't happen in children, usually it happens in adults. You might be able to see that on chest x-ray. Empyema, you know what that is? That's pus in your lungs. Okay, not good. Right. You can do blood cultures, sputum gram stain, culture of sputum, wounds, if you have any, or urine, are probably your best bet. Right. Standard cultures, blood cultures, more at the bottom of the line if you want to culture something to actually get something back. Okay. If you do have PCR, I would use PCR. All right. The other reason why I would use PCR, if you have PCR, would be because this is Staph aureus. You want to make the differentiation between Staph aureus MSSA, methyl Staph aureus, versus methyl-resistant Staph aureus. If it's MRSA, methyl-resistant Staph aureus, then you're going to have to treat with different medication. Okay? So that's why I would recommend trying to do PCR because it'll differentiate that for you. Otherwise, you do a culture, wait, and ask them to make sure whether it's do a culture sensitivity and wait to see what comes back from the culture sensitivity as far as what medications are going to help if it's MRSA versus MSSA. But we'll talk about that in the next block. All right, so if you look at day 1, okay, he's already pretty jacked up there on his right lung, right? But if you look at day 4, I mean, he's got complete whiteout of that right lung. Okay, 3 days. Okay, 3 days. Like I said, this guy's going to show up in your office. You're going to think he's got the flu. You send him home. 2 days later, he's going to come back and tell you worse. All right. Treatment, parenteral antibiotics. If it's MSSA, you'll do nafcillin. If it's MRSA, you'll do vancomycin. If he's got any infusion, if he's got any empyema, if he's got the empyema, then he's going to have to be inpatient because you're going to have to do a chest tube on him. He's going to have to drain all that pus out of his lungs. Right? If he's got abscesses, and he probably needs to be in the ICU, probably on a ventilator. There's your mortality, 40% even with therapy. Okay, so the sooner you can catch these guys, the better the outcome's going to be. And the sooner you can differentiate whether it's MSSA versus MRSA, your plan will be much better for a much better outcome. Okay. Other bacterial pneumonia. The other community-acquired pneumonias could be varicella, catarrhalis, Haemophilus influenza. We've got some hospital-acquired ones, intracranial pneumonias, which will affect those kind of folks. Proteus, Pseudomonas, Rhynchia. Not going to worry too much about those, but I will worry about Klebsiella pneumonia. Okay? If you see an alcoholic diabetic, or an alcoholic COPD, or an alcoholic with some other serious comorbid condition, one of the first things you need to think about is Klebsiella pneumonia. Everybody understand that? If you see an alcoholic with diabetes, or an alcoholic with COPD, or an alcoholic with some other disease process, and we're talking about pneumonia, one of the first things you need to think about is Klebsiella pneumonia. Okay. This is a facultative anaerobe. This grows in both presence of and the absence of oxygen. Okay. With this one, you should do a culture of sensitivity, right? So that you can specifically figure out the depth, what it is, and what medications are really going to work for this. There has been known, this has been known to have severe resistance against antibiotics. Here it tells you you're going to use piperacillin and tazobactam, okay, together. All right. I like to give you options. The other option would be IV ceftriaxone, okay, for this case, just because of the resistance. When you do that culture sensitivity, it'll tell you if it is resistant to piperacillin, tazobactam, and or cephalosporin, then you will probably have to use carbapenems. Okay? And that's a much stronger antibiotic that we try not to use if we don't need to. Okay? But this thing has been known to be very resistant to antibiotics. All right, so make sure you do culture sensitivity for this. Gold standard would be a culture for this thing, preferably from the sputum. But you can try blood, you can try urine. Has any abscess formations, you can try to do that from there as well. But culture is the gold standard. It's just going to take some time for it to come back. These folks are pretty bad. So if you do a chest x-ray, it'll probably have consolidation. So when you actually take a finger and you tap on your back, it'll sound solid. Okay. Now, one of the big things to know with this guy is that it's going to be very mucoid. But I highlight that, and I highlight the blood stain current sputum. And what that means is he's already leaking blood into his lungs prior to the cavitation. Right? And usually you'll see cavitation in tuberculosis, but in this case, the Klebsiella pneumonia is eating away at his lungs, so it's kind of leaking. Some of the capillary vessels are leaking into the lungs, so it's cough and cough up a little bit of blood, but generally it's enough that when his sputum comes out, it comes out in globs, and the glob is usually red. Okay? That's what we call current jelly sputum or blood stained sputum. All right? And this is generally what it looks like. It comes out, as you can tell, it's a glob, and it's just red. Okay? All right, bronchitis. Healthy folks, 39% result of a respiratory virus. Right? It could be anything. It could be influenza A or B. It could be parainfluenza 3. It could be a nasal virus. It could be an RSV. It could be a whole bunch of different things that can lead you to getting bronchitis. Okay? Bronchitis is just an inflammation of the tracheobronchial tree. That's it. A lot of times, it's following some sort of upper respiratory infection. That's all it is. Okay? We don't usually do much. We don't usually identify whatever it is that causes bronchitis. Because it can be so many things. smokers are extremely high for getting bronchitis. Okay, their ciliary reactions paralyzed from all the smoking that they've done. They can have squamous metaplasia, right, possible cancer from the smoking. So all that stuff contributes to irritation to that tracheobronchial tree, causing bronchitis. There, it says frequent isolates. We don't usually isolate stuff. And smokers, it's a little bit different. It's because we already know that they're going to have problems. So a lot of times, a lot earlier, the pulmonology folks will go ahead and do some sputum samples. But generally, we don't. Usually we'll just treat. Now, depending upon what caused this, if the person has it, as the individual continues to cough, he may spread it. So he may be able to spread it. Okay, here's some signs and symptoms. Productive coughs, sputum may be clear or purulent. Coughing, blood tinge. The blood tinge is from them coughing so much of irritation, they kind of bust little vessels, and that's really what you're seeing. So you're not going to see a lot of blood. Just little tinges sometimes, and it's only if they're really coughing extremely hard. All right. Okay. So prognosis of therapy, self-limiting, no antibiotics, symptomatic relief. All right. Now, if you look at the bottom, in pre-existing COPD, oral antibiotics are advised. Mild to moderate smokers, we would use amoxicillin. If you have respiratory problems, okay, this really becomes a serious issue. Right? Smoking, COPD, probably slap asthma in there too. Okay? If you have respiratory problems, I would go ahead and treat with the amoxicillin. All right. Standard folks like you and I, are pretty healthy. Do you need to treat? No. Self-limiting, it'll eventually go away. Okay. But again, in some cases, it ends up becoming your choice as a provider whether you will or won't treat. Pertussis. Bordetella pertussis, highly infectious. Okay? You can cough. Sound like a dog coughing really, really hard. All right? This is worldwide. It usually affects children and young adults. This is highly communicable. Okay? Mostly children, mostly adolescents, and it's caused by the gram-negative bacteria, Bordetella pertussis. Okay? Probably should remember that. That's probably the way it'll come back on the lab if you get a lab. Okay? Transmission is generally via respiratory droplets as you cough this stuff out. Okay, it's not necessarily pneumonia. It's a tracheobronchitis, very similar to bronchitis. But you'll have bouts of coughing, just coughing, 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 coughing. And then you'll stop. And then in the interim, you're okay. Nothing's wrong with you. But then you'll go back into another coughing phase. Okay? That's usually pertussis. And there it tells you post-us, you may have some gagging or vomiting depending on how hard you're coughing. Okay? And for little babies, they may have apnea spells, right? So they cough, 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 and then they can't breathe because they're recovering from the cough. Okay? And that can also happen to some of the younger children too, right? Depending on how hard or how much or how often you're actually coughing. So usually, because this is highly infectious, usually about the third week of having this, give or take, after that point in time, generally you're not considered infectious any longer. So usually about 3 weeks. Okay. Cough for greater than 14 days, 10% of adults get pertussis. Okay. If it is not pertussis, and talk about adults, you have to do a coughing workup. coughing workup is horrendous. Cough can be anything from cancer to influenza. So there's a lot of workup that you have to do if it is not pertussis in an adult. Alright? And there you consider secondary pneumonia, especially in children or infants. Kind of hard to say. You may see some diffuse or lobule infiltrates on chest X-ray. A lot of times, depending upon how hard these kids are coughing, is whether or not you will or will not see collapse of the alveoli on the chest X-ray. You can do direct fluorescein antibody testing or nasal pharyngeal cultures. You can do a PCR, still good PCR. Okay. This thing can last anywhere from 3 weeks to 3 months. So you've got a long time period that this thing can last, especially in kids. Okay. Treatment's supportive. You can use azithromycin or erythromycin to treat. Right? So we do have meds for that. But vaccination is key, right? Because we want prevention. So DTaP, okay, the P being for pertussis. Okay. At ages 2, 4, 6, 15, 18 months, and between 4 and 6 years as a booster. Okay. Here's the thing about coronavirus. It's been around since the 1960s. All right. That stuff with China, that was probably antigenic drift or antigenic shift. Okay. Now, new strain that popped out, became pandemic. It's just what happens sometimes, right? That's what happened with the Spanish flu. All right. The World Health Organization has reported more than 5 million people worldwide died. That number's way bigger now. Okay. In a short time, respiratory virus can spread into a wide geographic area. Nowadays, because of all the transportation and means of transportation and transmission that we have worldwide, right? I can go fish and have a fish here today, and tomorrow I could have it over in Europe. Right? We can just move that easy, that fast nowadays. Okay. So that's a lot of what actually has occurred with this coronavirus. The other thing that we have to remember and think about, and they're still doing studies on, is that some of those people that had minor or no symptoms or major symptoms of coronavirus post-COVID may have a condition called long COVID, where they have residual effect of the COVID in their system. And nobody really knows why, nobody knows who or what type of person will be most susceptible to that long COVID issue. Okay, that's still being studied. Here's a whole bunch of different coronavirus types. I actually wrote out what we got right now. So, right now, per the CDC, the Omicron subvariant KP.3.1.1 is the most prevalent strain. It is 50 to 60% of cases right now. Okay. That variant is going to continue to change, right? That's that antigenic drift and the antigenic shift that's going to continue to occur. So as it meets other strains, it'll change. Okay, but right now, that's the big one, right? The other one is XECJN.1 variant. It accounts for 14 to 22%, and it's showing a growing trend, right? So there's a next possible variant right there that you're noticing, and NB.1.8.1 is approximately 11% globally. And right now, the World Health Organization and the CDC are monitoring that one to see if it's going to continue to grow. Right? Because what they do is they look for trends to see if it's going to continue to grow, and if it continues to grow, then it becomes one of those that they monitor and or they'll start working on something to protect us from that. Okay. If you're not sure, remember this is a respiratory deal, so when people cough, sneeze, talk, yell, sing, they spread it to other folks. Right? So here are some risk factors for the coronavirus. Age, obesity is the biggest risk factor that they have found for folks that end up in the hospital. Okay. That is the biggest risk factor for ending up in the ICU. The other risk factors are for folks with underlying health conditions such as diabetes, pulmonary, and cardiac issues. The other thing to think about, because this is a respiratory disease, is folks with asthma, folks with COPD, those kind of folks. Although they're somewhat mentioned, it's still kind of weird to me that they don't particularly put them in the, hey, you need to really be careful with those types of folks. But although they've mentioned it, they haven't really made it a specific like they have with obesity. Okay? And then obviously any of the immunocompromised folks, any of them, whether it be lymphopenic, whether it be HIV, whether it be AIDS, those guys are always at risk. Okay, so fever, headache, sore throat, overall feeling of discomfort, body aches. Okay, so this kind of sort of seems like a flu, right? There's nothing here really that said, oh, it's COVID. Now, what I have found, loss of taste or smell, you don't have that in everybody. What I have found is shortness of breath is probably the greatest indicator of whether or not you need to be hospitalized or not. Okay. So from there we have this. Okay. You know this slide, right? So PCR test is the most common and reliable test for diagnosing COVID-19. Swab taken from nose or throat and test for the presence of virus temperature. Okay. That is the most common and reliable test. Okay. So I just want to point one thing out on this slide. PCR is used as an overall arching lab here. Okay. If we're talking a specific PCR, coronavirus is an RNA virus, so it should be an RT-PCR. But here, we're talking overarching PCRs, because there's quite a few different ones. PCR, there's qPCR, there's RT-PCR. So there's a couple of different PCRs. So here they're using PCR as an overarching, but if you're going to order something, it would be an RT-PCR. Okay? Just understand that it's still PCR. Most common and reliable test. An antigen test, a blood test, detects specific proteins on the surface of the virus, but it is less sensitive than PCR, but provides quicker results. Right? And then your antibody test detects antibodies produced by the immune system in response to the virus. It can indicate past infection, but is not used for diagnosing active cases. Right? So each one has its place. Right? And then remember, every location you're at and every installation has its own SOP for COVID management. So if you do have an outbreak, look at the SOP for whatever installation you're at, because there is one. Really need to know this slide. The main reason why you need to know this slide is because this is the way that the CDC uses to determine how you should be treated right now. All right. So here, for your mild illness individuals who have any of various signs or symptoms, okay, of COVID, without, keyword, without shortness of breath, dyspnea, or abnormal imaging. Okay. moderate individuals will have evidence of lower respiratory disease by clinical assessment or imaging and a saturation of greater than 93% on room air. Okay, so you're still at 93%, greater than 93% on room air. You're still okay saturated SpO2. If you look at and this is not going to be testable because the stuff is still changing, right? If you look at CDC requirements, right, they will say if you are mild to moderate, you need to isolate for at least 5 days from the time the symptoms started, right? And be fever-free for at least 24 hours without using medications, and you need to be showing improvement. That's for mild to moderate, per the CDC right now as it stands. Okay? And you'll need to continue to wear a mask for the next 5 days if you're around people. So it'll be a total of 10 days. 5 days isolation, 5 days wearing the mask. If you go back out. That is according to the CDC. If the symptoms are getting better, if you still have a fever, then you restart your isolation. Start again another 5 days. Okay. That is if you're mild to moderate. Okay, here's your mild to moderate definition. Now, if you're asymptomatic and you have COVID, what they say is you should isolate for 5 days, and then for the next 5 days when you're around folks, you should wear a mask. That's what the CDC says. But again, we're not testing on that because some of this stuff is changing quite often. Right? But what's not changing is the mild, the moderate, and the severe. Individuals who have respiratory frequency greater than 30 breaths per minute. What's our standard breath cycle? 12 to 20, right? This dude's already breathing at 30, so he's compensating, right? SaO2 greater than 93 at sea level, ratio of arterial blood pressure, arterial partial pressure of oxygen fraction inspiration, PaO2, FiO2 ratio less than 300. Okay? That ratio for a healthy person should be greater than 300 to 500. This person is already less than 300. Okay? Or having lung infiltrates greater than 50%. And you won't know that unless you actually do a chest x-ray. Right? For those guys, you either need to isolate 10 to 20 days, or you need to be hospitalized, depending on how you're handling your stuff. In most cases, usually we hospitalize those guys because their SpO2 starts dropping and they drop rapidly. Yes, sir.
Sir, for the severe illness, is it less than or greater than 93?
Should be less than, I'm sorry. Should be less than 93. Okay, treatment and prevention, mild illness. Most of the time, you can just recover on your own. Okay. Supportive care is all you really need. That's where you're mild to moderate, depending upon what your immune system is like, what your health overall is like. And then you have your moderate to severe. If you think you have this, or if you think your patient has this, and they do have some moderate to severe type of symptoms, give them medication as soon as you can. Okay, there'll be antivirals. The sooner you get this on board, the better your outcomes are going to be. Okay. You have a 5 to 7 day window to start those antivirals. Okay. You have a 5 to 7 day window to start those antivirals. Here we gave you 3. Remdesivir with ritonavir, which is Paxlovid. That one is for greater than 12 years of age. Okay. And it should be given within the first 5 days. Okay. Remdesivir is IV in hospital and should be given within 7 days. And then Lagvario is for adults only. It's oral. It should be given within 5 days. Okay. Now, if you notice anything else and you think they have some other type of bacterial infection, and it's your choice whether or not you're gonna give them some sort of antibiotic. Okay, provider's choice on what they see based on patient presentation. Okay? And here's got that big highlight of this is clinical judgment. All right, clinical judgment. Okay, these are some preventive measures, right? Nothing that you guys haven't already heard of. Social distancing, wear a mask, self-observance, self-quarantine, hand washing, cover mouth for coughing. Always use caution with immunocompromised folks. Nothing new that we don't already know, right? So, I'm not going to put too much effort on this. This is probably not going to be on your test, but just understand that every school system, every base, every hospital, and every clinic has its own SOP for dealing with COVID. All right? These things have been changing. Right? Right now, the end of isolation is after 5 days, unless you still have symptoms. So just keep that in mind that this stuff does change. Okay, this is other things that you should think about when you're going to say, hey, you should probably isolate for 5 days. Okay? Are they in the house with their family members? Can they go into a room by themselves, away from their family members, so that they don't spread it? Can they do that? Can they access food? Can they access water? Do they have their own bathroom? Okay? So there's a lot of other things that we should think about when we tell folks, hey, just go home and isolate. Okay. Do you have a family? Do you have someone that can help you? Do you have someone that can bring you food if you're by yourself? Okay. Do you have food at home? Okay. So keep in mind that there's a bunch of other things that we need to think about, that we need to let them know when we tell them to isolate, that there's other things that they need to check on when they're in there by themselves. All right? And or what to do if they start getting worse. Okay. So monitoring for the evolution of symptoms. How do you keep track of those guys? How do you know that they're not getting worse? So here's my story. I'm in Saudi Arabia working with the State Department. I have a compound with some military folks, but mostly civilians. Mostly civilians with comorbid conditions. Mostly with civilians that should not be over there. Okay? Because they're overweight, they have diabetes, they have asthma. I'm like, how did you get over here? And they're like, you don't need to worry about that. I'm like, I am now, right? So there was two of us. It was me and my doc, right? Two of us. My doc happened to leave the country on leave as they closed the borders down. So nobody could fly in and nobody could fly out. Guess what? Now you got a PA taking care of a bunch of sick people that I should not have been left alone. That is not good, right? This is where I tell you, hey, if that SpO2 starts dropping, that is a huge indicator. There are plenty of studies that back that up. It is a huge indicator that those folks are going to end up in the hospital. So we had a couple, right? So what we used to do, me and the medic, we would put in our little bunny suit, we'd put on our goggles, we'd put on our N95 mask, and we'd go outside. Everyone lived in a little villa, so we'd pull them outside to the front courtyard, and on a little chair, I would just have them go up and down, sitting and standing for 15 seconds while we were monitoring their SpO2. Okay? If that SpO2 started dropping over time, right, because we're looking for trends, it's like, hey, we're going to keep more of an eye on you, and we'll see if you start deteriorating. If you do, I had to take you to the hospital downtown. There was one time we went to 4 different hospitals before we finally found one that would accept the patient, because they were so full. Right? But with what we're looking at here, And my point is, on some of these, what we would do is we would have them just iPhone us face to face, so we could see them, and then we could talk to them, without having to go to their place and put on our little bunny suits all the time. We still had to do that to manage their SpO2 to see if they were gonna tank, because there were a bunch of older people with comorbid conditions, but it was as simple as them calling us on the phone, doing an iPhone face to face. How are you feeling? What are you looking like? Right? We got enough SpO2 readers that we gave folks, like, hey, put that on and see what it's looking like. And they would put it on, they would tell us the number, or they would show us a little SpO2 reader, and we didn't have to go over it. Right? We didn't have to go over it, which is kind of nice. So we can leverage technology, in this case, to be able to monitor some of these folks without having to go check up on them face to face. All right? That's what some of this stuff really means. All right? So there it says, although 81% of Chinese case series had mild symptoms, those who progressed to more severe disease were hospitalized a median of 7 to 11 days after the onset of illness. So what that's telling you is a week after that onset of illness, that SpO2 may have dropped, and those are the folks that you're going to probably have to hospitalize. Okay? And these are just looking at studies and statistics for you to kind of sort of be aware of. All right, when's that time frame where this guy may like really take a nosedive and I really have to take care of him, right? Or really be concerned? And it's usually the beginning of that second week. It's usually when you start having to have concerns if folks are going to start tanking or not. Okay? And close monitoring should be emphasized in any patient who's identified as being at high risk for severe disease. And there it tells you, monitor via telehealth may be an option for patients. There's a whole bunch of little links there at the bottom for you to click on if you want to go to the CDC website for handouts and things like that. Okay, guys have any questions? Yes, no, maybe? All right. I will be up here for a couple more minutes. If you guys have any questions, this concludes our block, hour